I would like to introduce our speaker of the lecture on COVID-19 in Hong Kong. What does the future hold? Dr. Siddharth. Yeah. Dr. Siddharth has been a good friend of the association. We have been introducing him to give us lectures on COVID-19 during the previous webinars. Yeah. And Dr. Siddharth has precisely tell us what will happen right before the explosive of the fifth wave. Yeah, and then this help us, our members, to take precautions and all the necessary measures in order to protect themselves and their patients. Yeah, everybody know that Hong Kong has been recently emerged from the severe fifth wave sparked by the highly transmissible Omicron variant. It is estimated that 60% of Hong Kong population was infected during this explosive wave, which also led to heavy casualty. As life in the city normalizes, it is natural to ask what lies ahead. Is the sixth wave inevitable? And if so, how can we prepare ourselves? In this lecture, Dr. Siddharth will explore various aspects of Hong Kong immediately COVID-19 future, including a summary of current circulating Omicron lineage virus that have a potential of causing the next big global wave. Dr. Siddharth is a clinical assistant professor at the Department of Microbiology of the University of Hong Kong. He is a clinical virologist with a special interest in emerging infectious disease and their impact on vulnerable patient groups. Dr. Siddharth is actively involved in the COVID-19 research and has published several studies on COVID-19 diagnostic assay deployment, serial epidemiology studies, animal models, clinical pathological research, and surgical mass efficiency. Dr. Siddharth is also keenly involved in community engagement on COVID-19 through both social media and traditional media. May I now invite Dr. Siddharth to deliver his lecture. Members who have questions may put forward these questions at the Q&A sections immediately after Dr. Siddharth's presentation. Dr. Siddharth, please.
Thank you so much for the kind introduction. I'll just share my screen now and we can begin. Let's see. Okay, you should be seeing the slides now. So I hope you can hear and see the screen properly, and I'll begin. Thank you again to the Hong Kong Dental Association for this kind invitation for this talk. And it's been quite a journey, because I remember the first time I spoke to this very esteemed association was back in 2021, just when the vaccination campaign in Hong Kong was starting to be rolled out. And it's been quite a journey since then, as I'm sure everybody would agree. And our lives have changed in many ways. But now, Hong Kong has been through a very, very traumatic experience, I would say, in the last couple of months. And that has inevitably changed the picture for Hong Kong in particular. And it now becomes a kind of important question to consider what lies ahead for the city. So I thought I'd do something very difficult today, which is to try and get a glimpse of the future. Predicting the future is always something that's very difficult, because most people have a 50-50 chance of things turning out to be completely different. And there are lots of variables here, but I still think it's worthwhile to kind of have a look at Hong Kong's immediate future, because that is going to affect all of us. So that is the reason for this particular lecture title, right? What does the future hold? So let me get my pointer up and we can begin. Now, to understand the future of COVID-19 in Hong Kong, at the moment, we still have to understand the importance of this particular variant, which is the Omicron variant, which has really changed the game in terms of COVID-19 globally, And this was the variant that basically caused Hong Kong's fifth wave, to be very, very simplistic about it. The Omicron variant is very different to the variants that came before it. I briefly touched on this in the last time I spoke in February 28th of this year. The Omicron variant basically is antigenically very different. What that means is that the spike protein of the Omicron variant carries a huge number of mutations, actually an unprecedented number of mutations compared to previous variants. And this makes the virus very, very different compared to the variants that came before it. The implications of so many mutations basically means that Omicron is able to infect people who were previously infected or vaccinated. So all around the world, people who had been infected by other variants like Alpha or Beta or Delta suddenly found themselves completely susceptible to Omicron. Similarly, people who had received 2 doses of Omicron of vaccines, COVID-19 vaccines, also found themselves to be susceptible to Omicron. And that resulted in huge waves around the world. Luckily, almost in every part of the world, the Omicron wave has largely been less severe than previous waves. So compared to, for example, Delta, Omicron certainly seems to be intrinsically less virulent. And the other factor is that everybody in lots of people in other parts of the world have already caught COVID before or have been vaccinated before. So although they're still susceptible to Omicron, the severity of the disease that it produces is lower. So the Omicron waves around the world have generally been less severe than Delta, both because it's intrinsically less virulent and also because people all around the world have been exposed to some form of COVID-19, either via infection, vaccination, or both. Both of these contribute to the reduced virulence of Omicron. However, back in February, I did note the general consensus among experts in Hong Kong that Omicron would cause a lot of damage in Hong Kong in terms of severe disease because of its high transmissibility, and also because, unlike other parts of the world, our vaccination rates in the elderly population is very low, and the rates of prior infection obviously is almost zero. Actually, we had very, very few local COVID-19 cases relative to other parts of the world. So that means we're basically talking about a completely naive population, especially for those who are unvaccinated. So, I mean, after that, we all know how things turned out. Hong Kong's Omicron story was heartbreaking in many ways. And one thing is for sure, Omicron in Hong Kong was the city's worst public health emergency, historically speaking. It was worse than the Great Plague. It was much worse than SARS. It was a very dark period for the city. And I'm sure we all remember images such as this of beds lining up outside emergency departments. And in retrospect, it's very predictable, right? Because unfortunately, infection rates were very low in the city, plus vaccination rates in the key elderly population resulted in lots of chaos. So why I'm going over this in some detail is because to kind of get a glimpse of the future, we do have to understand the reasons for why things turned out the way they did in Hong Kong. This is a very striking graph. In the above graph, you see the new cases per million in various developed regions in the world. You would see that at the beginning of 2022, most parts of the world, including these selected regions, had spikes in COVID-19 in terms of new cases per million, and Hong Kong is included here. And you would see that just like other places, big Omicron wave in Hong Kong. This is completely expected, super transmissible virus, very, very densely populated city, very cramped housing, households, household transmission through the roof. That's what you're going to get. But Hong Kong was completely different to other parts of the world in terms of the number of deaths per million. So you look at the deaths per million, Hong Kong is a striking outlier compared to other developed regions. And so why was this the case? I'm sure all of us know the answer, and this is again something, as I said, that's completely predictable. The reason for this was because of the low vaccination rate among a key vulnerable segment of the population. So this was the vaccination rate that we had heading into the fifth wave in Hong Kong, and you can see that it's actually the opposite of many other parts of the world, which prioritize elderly vaccination. In Hong Kong, the percentage of the population that had received any dose of the vaccination, 1, 2, or 3, was generally higher in the younger age groups, actually very, very respectable in adolescent, and extremely high, I would say, world-beating rates in the younger age groups. But once you get to the older age groups, the picture actually reverses. And you see that the rates of vaccine uptake are actually very poor. So when you come to the most vulnerable segment of the population, that is above 70, you would see that a good fraction of the population is completely unvaccinated. And this really is the single most important contributing factor to the way Omicron turned out in Hong Kong. Moving on, this is data that's compiled by the Center for Health Protection, and they looked at different age groups, and they looked at a very, very simple crude case fatality rate. So it's basically the number of deaths over number of cases in each age group. And you would see something that's true for COVID-19 anywhere in the world. As people get older, they have a higher mortality rate. It's a very, very straightforward relationship. There are a lot of cases of children dying during the course of COVID-19 infection in Hong Kong, but I would like to remind the audience that this remains extremely uncommon. Okay, so children dying of COVID-19, even one is unacceptable, even one is too much, but compared to the elderly population, the case fatality rate in the pediatric population is actually much, much lower. In the elderly population, you can see the jump from 70 to 79 compared to plus 80. There is a jump by more than 10% in terms of the case fatality rate. Now, the interesting thing is when you split it up depending on whether they're vaccinated or unvaccinated. So if they're vaccinated, essentially the risk of dying gets much, much lower. So, and this difference is particularly pronounced when you look at older age groups. Now, when you look at younger age groups, there is a difference, but it's not particularly striking. We're talking about 0.0 or 0.01 compared to 0.1 something %. And that's because these, as I said, these age groups generally have lower mortality rates due to Omicron in the first place. But when you start getting above 50 or above 60 or above 70, there is a really stark difference, okay? So if you look at the above 80 population, among unvaccinated 80-year-old plus, you have a case fatality rate of 13.3%, but this drops to about 3.3% for those with a history of at least 2 doses of the COVID-19 vaccine. So it's really a very dramatic difference. And, you know, you would hear about people theorizing that a lot of these deaths were with COVID instead of due to COVID, and you'd hear a lot of that, but I tell you, if that was the case, then you wouldn't see this clear difference based on vaccination status. So it's very clear that COVID-19 is actually a very, very severe infection for the elderly, and vaccination with even at least 1 dose can actually dramatically get this risk down, even in the age of Omicron. And I'll bring up data on this in subsequent slides. Vaccination is by far the most important, but not the only factor. We do have to remember that residential care homes in Hong Kong do tend to be very crowded and occupy a very small area, and may not often have very state-of-the-art ventilation. So unfortunately, this lent itself to explosive outbreaks in elderly homes. And our healthcare system was under extreme stress, and I can definitely confirm that it does affect our ability to provide world-class care. There is no doubt that healthcare and public hospitals during COVID-19 suffered, right? Because the system was under so much stress. And I think as healthcare workers, we all appreciate why that might be the case. And the last reason is because until the middle of March, we did not really have a great system for deploying antivirals in community settings. One oral antiviral, molnupiravir, became available in hospitals at the end of February, and the second Paxlovid started to come out in the middle of March. By then, unfortunately, we had already seen a lot of mortality due to COVID-19 in Hong Kong. The peak of the cases in Hong Kong was in the early March, and the peak of mortality was in the middle of March. So we got these tools a little bit too late. But now it's a different story. The number of deaths after its peak in the middle of March is coming down nicely. And in terms of cases, we have about 200 to 300 cases per day. It's kind of settled at this trough for some time now. We see a lot of society opening up. Ocean Park is open again. Disneyland is open again. Kids are starting to go back to school, although they need to do their rapid antigen test daily. For a lot of them. And in terms of, public areas, I'm sure all of us have experienced these large crowds in outdoor settings, as well as restaurants, excuse me, over the recent public holidays. Now, the fifth wave, the actual scale of the fifth wave has been estimated in a modeling study by the Center for Data Discovery and Health in the University of Hong Kong. And they estimate that by the end of last month, 4.3 million of Hong Kong has actually been infected with Omicron. So that essentially translates to 60% of Hong Kong's population, which has probably been infected. Now, this is a model, okay? It shouldn't be taken as the gospel truth, but this is really one of the best estimates we have as to how much Omicron there was in Hong Kong. There will be seroprevalence studies going on in the city as well by multiple universities, and we should get a very, very accurate estimate of how much of the population of Hong Kong is actually infected with Omicron very soon. But this is a very decent estimate. Official estimates say about 1 to 1.5 million, but we all know that there were significant underestimation of cases because of lack of access to diagnostic services and lack of recognition of RATs, and a lot of people simply choosing not to get tested. And we estimate that official figures might reflect about 25 to 30% of the actual caseload. So that's, as you can appreciate, a significant chunk of the population. Right. So now that we understand what happened in the last 2 months, we are now in a position to kind of take stock of where we are now in this very peaceful interlude when society seems to be going back to normal. Businesses can function, children can go back to school, and we can start enjoying life a little bit more. But the question that I think I want to address first is, will Hong Kong have a rebound in cases? I want to say that this is 100% going to happen, and it's going to happen very quickly, right? Whatever we do at the moment, in terms of the order of relaxation of social distancing measures, a rebound in cases is definitely going to happen based on the global experience of the last 2 years. So let's just get into the mindset of accepting this, so we can face the future with a little less fear and more equanimity. Now, why do I say that we are definitely going to have a rebound in cases? Well, multiple reasons here. First of all, we have to appreciate that 60% of Hong Kong might be infected, but 40% is still uninfected. And most of these uninfected folks haven't received, 3 doses of COVID-19 vaccine, which is what it would take to really confer any degree of protection against Omicron infection. So we have a large unboosted population. Correctly, the Hong Kong government has relaxed social distancing measures to give the population a break. This is absolutely the correct thing to do, but as emphasized by the recent restaurant outbreak, the Phoenix restaurant outbreak, relaxation and social distancing is going to result in outbreaks across the city. So this is absolutely guaranteed. And I think another important point that I want to raise is that we have 200 to 300 cases per day in the city. Many of these cases, the contact tracing may not be completely exhaustive. So there are going to be hidden transmission chains across the city. So with all of these other factors, these are going to be kind of the sparks that set off an Omicron outbreak. The next factor is that we have relaxed quarantine requirements for incoming travelers, which again is a big relief to the city's economy and is absolutely the right thing to do. But there is then what we have to give in exchange for that is a slight risk of introduction of newer subvariants of Omicron, which I'll cover at the end of this lecture, that may again spark outbreaks, that have the potential for sparking outbreaks in the city. The last point, why rebound of cases is absolutely guaranteed, is because those who were infected during the fifth wave are slowly going to get waning of antibody levels, and this is going to make them resusceptible to infection. So, basically thinking about those who are infected in January or February, by about 6 months' time, we do know that there is an increasing risk of reinfection among those who are recovered. So what that means, all in all, is that, there is going to be a rebound in cases. Now, that sounds like bad news, but what I want to emphasize is that it is such a rebound, I think you can call it a sixth wave, is definitely going to be less horrible than the fifth wave, because things are different in Hong Kong with respect to the population immunity and the vaccination rate, which may not necessarily protect against infection, but does protect against severe disease. So I'm not saying this in order to make people afraid. I'm just saying this so that we can be prepared for a rebound, and we understand that that actually may not be the end of the world, right? It's not like the fourth wave setting to the fifth wave setting, where we know that an introduction of cases into the community is going to result in an uncontrolled lethal outbreak. For after the massive fifth wave, we do know that there is a good level of population immunity against severe disease, and this is really going to help us, even if there should be a lot of infections in the sixth wave. Now, what is really unpredictable, however, is policy. Now, I always say the viral or virus behavior is kind of predictable, especially after 2.5 years. We really do understand a lot about this virus. But what is unpredictable is actually how Hong Kong is going to deal with this from a policy perspective, because there are a lot of moving parts in the government's calculations in terms of harmonization of practices with mainland and considerations of the border reopening with the mainland. A lot of things going on, and these are not necessarily scientific considerations, right? There are other factors involved here, but faced with the rebounded cases, the government may choose to go in two directions, and these options were actually laid out in the modeling study that I referred to previously, and it's an excellent document which I would really emphasize and would really encourage everybody to read if they should be interested. There are basically two options. The first option is really to go back to where we were in December of 2021, and to say that a rebound in cases should trigger a set of actions that is compatible with bringing cases back down to zero as much as possible, okay? What that would involve is community universal testing, which has been repeatedly proposed but hasn't actually happened in Hong Kong yet, school closures, strict border control, heightened social distancing measures, or even a mainland style lockdown, which we are seeing in Shanghai and Beijing now. So this, in a way, is option one. The second option is what we call a controlled transition towards endemicity, okay? So what that would entail is sensible public health measures that are closely linked to hospitalization data or severe disease data. So if you see hospitalization and severe disease tracking upwards, you actually introduce measures that, sensible measures, not extreme measures, that actually bring the case numbers down to a more manageable level. But this basically means that there is some degree of tolerance to substantial transmission in the city. The same modeling study that I talked about previously actually estimates that if a sixth wave happens, they estimate the timing around June, but we don't really know. It may be earlier than that or a bit later than that. They estimate that that would actually entail 2.2 million infections. So we're talking about a big wave here, but there are ways that we now have access to that we can actually reduce the burden on healthcare care quite substantially. But I don't want to sugarcoat it. 2.2 million infections is definitely going to cause some degree of disruption to society, as well as pressure on healthcare services in primary healthcare, as well as emergency departments. So that is going to happen. Now, once that happens, we truly say COVID is endemic in Hong Kong, and we kind of rejoin the rest of the world, which has completely gone down this path already. Okay, so there are two options really. It's very hard to do something in between. So I would honestly like to be very clear that it's really either option one or option two. So there's a little bit of uncertainty at the moment of which direction we're going to go in if there is a rebound in cases. Now, one important thing that I would like to emphasize is that even if we go for zero COVID, in the medium term, we do have to understand that it's a transitional stage, that eventually, even with this, we are going to have a rebound in cases. Think about what happened in December 2021. We were strongly zero COVID, but in January, everything changed. Now that whole process, no matter how careful we are, that process can repeat again. So we do have to acknowledge that this is still, this is a transitional phase, right? So, I guess it's a matter of some reflection as to which path Hong Kong is eventually going to follow. Okay, now I guess what I do want to talk about here is that irrespective of whether we go down dynamic zero or transition to endemicity, we do have to get used to this idea that our focus cannot be entirely on preventing infections, because you really have to shut down a lot of society in order to achieve any degree of control over infection, which causes a lot of damage to people's livelihoods and society's normal functioning. So our focus has to increasingly be on improving access to pharmaceutical interventions, right? Before, for the first 2 years of the pandemic, our focus in Hong Kong was always on non-pharmaceutical interventions like school closure, border closure, this and that basically helps to prevent people interacting with each other, social distancing, etc. Prevents people interacting with each other and prevents them transmitting the virus in this way. But increasingly, we have access to pharmaceutical interventions that actually prevent severe COVID-19 in vulnerable groups. And we have to build a certain degree of acceptance that the rest of society is going to see a lot of infection. There is always circuit breakers that if you have a lot of cases, severe cases, or you know, an increasing healthcare burden, then what you can do is to actually try to circuit break in order to introduce sensible social distancing measures, as I talked about before. But really, it's all about these pharmaceutical interventions. There are two types of pharmaceutical interventions that are going to be very, very important that I would like to talk about a little bit in this lecture. And they would include vaccines, an appropriate number of doses, and antivirals, vaccines and antivirals. Now, I've been talking about vaccines and how good they are since 2021, but I think what really is different now is that we have local data. We have very strong local data now based on our fifth wave experience. And here you can see this excellent study by the School of Public Health that analyzed severe and fatal cases during the fifth wave. And they find that across all age groups, the percentage of cases that develop severe disease or fatal disease, the largest percentage are largely unvaccinated. Okay, and vaccinated, the rates are relatively low. And these are the vaccine effectiveness figures that they come up with. Now, mild to moderate disease, you would notice that whether it's 1 dose, 2 dose, or 3 doses of either vaccine, the figures are relatively lowish. The best is obviously BioNTech with 3 doses, but honestly, we don't care about this anymore. We're not really focused on preventing mild or moderate COVID-19. Our focus really is to prevent severe or fatal disease or mortality, right? So this is combined severe fatal and this is mortality alone. And here what you'll find is that whichever vaccine you receive, as long as you receive 1 dose or above, you're going to have fairly sterling protection against this combined outcome of severe or fatal COVID-19. If you receive 3 doses of either vaccine, irrespective of age group, you actually have excellent protection compared to unvaccinated individuals. So it's in the Hong Kong setting, in the 5th wave, our vaccine effectiveness of 3 doses of either vaccine was very high. And I would say for most of the 5th wave, vaccines were the elderly's best friend. So those that decided to get vaccinated, it basically did much, much better than those that did not. And that really applies almost irrespective of whether you get 2 doses or 3 doses. I think one thing that needs to be emphasized here for the elderly population, you look at CoronaVac, the vaccine effectiveness against severe or fatal disease is a little bit lower. But if you give them the 3rd dose of CoronaVac, the vaccine effectiveness jumps to nearly 99%. So I would like to emphasize that for the very elderly population who choose to get CoronaVac, it is really a 3-dose vaccine. It's really a 3-dose vaccine. So that is something that I would like to emphasize. Now, does vaccination carry other advantages? Yes, actually, vaccination enables something called hybrid immunity, which is the idea that immunity against COVID-19 that is obtained after vaccination plus infection is better than infection alone. And that is what has been confirmed in different parts of the world. This is an Austrian study looking at this idea. If you just focus on this panel, you look at for people without previous SARS-CoV-2 infection or vaccination who developed an Omicron infection, their antibody responses are largely against the Omicron variant. And that makes sense. Their antibodies against other variants of concern that were previously circulating is pretty low. But if you have a vaccinated individual who develops a breakthrough Omicron infection, the antibody levels against many different variants of concern is actually boosted. So you have this concept of hybrid immunity. And that was actually also confirmed in a recent local study that essentially found that if you develop a breakthrough infection due to Omicron, if you're vaccinated, your antibody levels against other variants like Delta, Beta, or wild type get a really substantial boost. But if you're unvaccinated and you develop a Omicron infection, then unfortunately, the antibody responses against other variants, such as Delta or Beta, is actually not that great. So that's where the concept of hybrid immunity kicks in, that if you get infected plus vaccinated, it really does tend to broaden your antibody responses, the depth of your antibody responses. Please note that I'm not encouraging you to get infected if you're vaccinated. What I would just want to emphasize here is that even if you develop a breakthrough infection after vaccination, there are some advantages in terms of really broadening and deepening the kind of repertoire of antibodies you produce. And this has been a very convincing experience from the laboratory side. Great. So this is, again, something that a few members of the audience might know about Hong Kong's stance on the 4th dose. And it is currently recommended for individuals above the age of 60, I believe. And the reason for that was because of this Israeli observational study that essentially found that an additional dose in the elderly population did have a substantial improvement in rates of hospitalization or COVID-19 death compared to 3 doses alone. Again, I definitely do not think that this should be mandatory, but this should definitely be an option for elderly individuals or immunocompromised individuals who seek additional protection. And that is the spirit of the recommendation in Hong Kong. So it's actually quite confusing at the moment, but this is the link to the government's current recommendations on how many doses you need. Essentially, as you know, that basically all of us would need 3 doses. If you're not previously infected, you would need 3 doses to fulfill the requirements for vaccine pass in a lot of public areas very soon. So that's coming up. But if you've had an infection, that basically counts as 1 vaccine dose. So then you just have to refer to this table to kind of figure out how many doses you need if you are unvaccinated before your Omicron infection. So that's there. And it's actually relatively well accessible via this CHP link. We do now say that if you've had COVID-19 infections, you can get vaccinated by about 1 month after recovery. And that's actually perfectly safe, right? So that is that. So the 4th dose, basically 3 doses after an infection, is again recommended for the older people or for those who are immunocompromised, although this is not part of the vaccine pass at the moment. Great. Now, the other part of pharmaceutical interventions, in addition to vaccine, are the oral antivirals for SARS coronavirus 2. And these also, hopefully, are real game changers when Hong Kong faces its 6th wave. There are 2 drugs that I want to talk about. There is a 3rd drug that's available in Hong Kong called intravenous remdesivir, but because that's an intravenous drug, they actually can't give it in community settings, so I won't go over that. Although it's also pretty good for prevention of severe COVID, as well as reducing mortality in hospitalized individuals who require oxygen. But I want to talk about the oral drugs because these are the real game changers in a community setting. And these are available via designated clinics of the hospital authority, as well as some private clinics, I believe, are also have the ability to prescribe these. So the first drug that I want to talk about is molnupiravir, which is the drug by Merck. Suffice to say, without going into a lot of detail, how it works is basically it causes the virus to mutate. Now that sounds funny, but if viruses mutate too much, their population actually collapses. There's something called the lethal mutagenesis threshold. And that's how it works. It's given as a 5-day course at 800 milligrams BD. Remember that oral antivirals for COVID-19 are only effective at preventing severe COVID. So you have to give them for patients, to patients who are within a certain amount of time post-symptom onset. So within, say, 5 days. So if you give it to a person beyond, say, a week after symptom onset, they're not likely to be effective because the viral load is already dropping by then, irrespective of whether the patient progresses to severe COVID or not. So you have to give it early. That's the most important thing. They're actually, molnupiravir is fairly good as far as tolerability is concerned, and it doesn't require dose adjustment or no known drug-drug interactions, etc. The main problem with molnupiravir is you cannot give it to adolescents or children. You cannot give it to pregnant women because there is a concern of effect on bone or cartilage growth as well as teratogenicity. And in fact, for males or females of reproductive age who take molnupiravir, we do actually have to give them contraceptive advice. So 3 months after the last dose for males and 4 days after the last dose for females to avoid potential teratogenic effects. Molnupiravir for oral treatment the recommendation is based on this landmark clinical trial that has since been published in the New England Journal of Medicine. And the course is basically for 5 days of oral molnupiravir to high-risk individuals who present within 5 days of symptom onset, who are not hospitalized or requiring oxygen. Basically, it's for early mild COVID. You want to prevent severe COVID. What they did find is that there is a 31% reduction in hospitalization or death compared to placebo. Kind of disappointing. You would notice that the error bars kind of overlap at different times, but yeah, it seems to work. Generally, the results were in favor of molnupiravir versus placebo. But again, as I said, questions have been raised whether the authorization was premature. People have looked through the results and they do feel that the results have borderline significance, and even a small amount of misclassification in the trial could essentially overturn the significance of the finding. So it wasn't exactly a very robust conclusion from the clinical trial, but because we really need an antiviral, it was approved. But we really need post-marketing surveillance to see how much difference molnupiravir makes to people, and that's very important. The other drug, which is considerably better, is Paxlovid. The scientific name is nirmatrelvir ritonavir. So it's a combination of a new drug called nirmatrelvir, which is inhibits one of the enzymes of COVID, and ritonavir, which is basically for increasing the nirmatrelvir levels. This is a drug that is specific for coronaviruses. It's again given as a 5-day course, and it does have some contraindications when it comes to severe renal or hepatic impairment. It can be given to adolescents, cannot be given if patients are younger than 12 years of age. Main problem with Paxlovid is that it has multiple drug-drug interactions, mainly because of the ritonavir component, which acts as a cytochrome P3A inhibitor. Huge list of drugs that you can't take together with Paxlovid, and this makes prescription a little bit difficult because you really do have to go over the drug record of the patient to make sure that there are no interacting drugs. But the reason why I really like Paxlovid is because in the clinical trial, it was actually very substantial in terms of its differences in primary outcome rates between the treated and the placebo group. Again, very similar to molnupiravir, you give it for 5 days. Within 5 days of symptom onset to people who are not hospitalized but have risk factors for severe COVID-19. And what they found in the clinical trial is that there was actually a large percentage difference between people taking Paxlovid versus placebo for the primary outcome of hospitalization or death. So looks like an excellent drug. So based on this, these are the US NIH treatment guidelines that basically, in order of preference, they really prefer giving Paxlovid as the first line for people who are in the community, who are not hospitalized with early COVID-19, who have risk of progression to severe disease. So we're talking about people who are old or with people with multiple medical comorbidities. You would notice that molnupiravir has really been downgraded in the US only if Paxlovid is not available. They do have a monoclonal antibody product that's not available in Hong Kong, so I don't want to talk about bebtelovimab. But in Hong Kong, usually we have both molnupiravir or Paxlovid for elderly with risk factors for progression to severe COVID. My general recommendation is try to use Paxlovid wherever possible. If there is a potential drug-drug interaction, I would assess if the other interacting drug can be discontinued for the duration of Paxlovid treatment, because it's only 5 days. It really does make a difference compared to molnupiravir. Whichever drug you give, it is important to give it early, and it's important to give it to people who really have high risk of severe COVID. So for somebody who's at a younger age group or adolescent, their risk of severe COVID is so low that you really don't have to bother treating them with these drugs. But if you're talking about an older person or somebody with multiple medical comorbidities, it becomes very important to give them antivirals early. And a big challenge that Hong Kong faces is how to improve delivery of these effective antivirals in community settings, because once people are always going to delay seeking healthcare. So if you wait for them to actually get admitted to hospital first, it's going to cause a significant delay in time to administration of these drugs, and it's going to affect the how effective these drugs are going to be in those patients. So we have to really work on how we deliver these drugs effectively in community settings, in pharmacies, by general practitioners, or even by CGAT, like community geriatric teams in old age homes. So we don't want to treat people with these kind of drugs in hospital settings. Okay, so now I'm getting towards the end here. This is the last theme that I want to talk about, which essentially is about variants. This is something that people are very worried about. They'll say you can relax now, but how do you know when the next variant of concern is going to arise, and what's that variant going to look like? here's what I promise you: nobody can predict how a virus is going to evolve. It is inherently unpredictable, and any virologist who tells you that they know how it's going to evolve is lying. Okay, we have no clue. But what I will say is there are some things we do know. We know that it's definitely going to happen because SARS-CoV-2, like all viruses, mutates all the time. In addition, the SARS coronavirus 2 has a large animal reservoir. There are many parts of the world in which sequencing is not carried out very thoroughly. So there might be these unknown variants that are actually already circulating in human populations in some parts of the world. And if you have immunocompromised individuals who are infected, they can actually harbor chronic infections in which the virus develops a lot of intra-host heterogeneity. So there's a lot of diversity building up in these centers. So we can't predict when and where, but we do know that variants will definitely emerge. When you hear the term variant or mutant, you don't have to be too worried because the majority of variants don't achieve the kind of fitness and that is required for global dominance, and they will eventually die out. Only a few variants have achieved this kind of global dominance, and they would include things like Alpha, Delta, and Omicron. So these are the three successful examples at this current moment. But there are tons of other SARS-CoV-2 variants that simply have not made it. Now, I said we can't predict much about the new variant of concern, but what we can predict is if some variant replaces Omicron, it would have to be even more transmissible than Omicron. That sounds crazy, but by definition, it has to replace Omicron. So it has to have some advantages over Omicron, right? It has to be either intrinsically more transmissible, or it has to be able to escape immunity generated by previous infections or vaccination, or some combination of both. Omicron is exactly the same. It is intrinsically more transmissible, and it has immune escape potential. So it occupies this overlap very nicely. The severe virus doesn't care whether it kills the host or not. Because the way COVID-19 is, SARS-CoV-2, the viral load peaks early during the disease. So a lot of transmission happens very early in infection. So it doesn't really matter to the virus what happens to people after they're infected. However, what we can say is that as vaccination rates build up, or as infection rates build up, most of the world is either vaccinated, infected, or both. The chance of the variant of concern being more severe than previous variants gets lower. And that's exactly our experience with Omicron. So the good news is that although it's more transmissible, in a setting like Hong Kong, where there's so much past infection or vaccination, the chances of severe disease are generally lower. And because of this, it makes no sense to have a lot of flight suspensions or a lot of prolonged quarantine types for incoming travelers, because our community generally is more resilient to COVID-19 after the fifth wave. So I hope that, again, that helps to lower the kind of fear that we have about variants of concern. So we are now in a different world in 2022. So, okay, so having said all that, there are no candidates for a new variant of concern at the moment. At the moment, Omicron is absolutely the main circulating variant. It has almost eradicated Delta circulation worldwide. It is extremely fit at the moment. In fact, we are now looking at different sublineages of Omicron, and the one that is most relevant to Hong Kong is BA2. And this is the one that caused the fifth wave in Hong Kong. And BA1 is the one that caused large waves in many parts of the world, but the one that was in Hong Kong was BA2. There are interesting sublineages or descendant lineages or possibly sister lineages of BA2 with potential mutations enhancing transmissibility or immune escape slightly. These are BA2.12.1 in the US and BA.4 and 0.5. But generally speaking, we do expect vaccines and antivirals to work very well against severe disease from these variants. So it's really more of interest to virologists, yeah. So this is kind of some of the experience. South Africa, once again, is seeing a large spike in BA4 and BA5, and it's replacing BA1 and BA2 that caused a lot of disease there previously. And it is possible that BA4 and BA5 would have some transmissibility. In fact, this is confirmed. It has some transmissibility advantage over BA2 in terms of both inherent transmissibility as well as ability to infect those who are previously infected with BA2. So there you go. The virus never stops, but all respiratory viruses are like this. So this is, they constantly spin off new lineages. Think about influenza. We need to update our vaccine every year because of constant antigenic shift. And this is exactly the kind of antigenic shift we're seeing in Omicron. So again, some really routine for respiratory viruses to do this, and not something I would say that we need to be very worried about. The other interesting thing that came out in the news recently, so I just put a slide on this, is recombinants. Recombinants are different from what I was talking about before. Recombinants are basically combinations of two different variants. So for example, this is the genome of the Delta variant, this is the genome of BA1. So you can basically have a daughter virus, which is a combination of one segment of the Delta genome and one segment of the BA1 genome. So that they have a lot of fancy names for this, like XF and XS and XD. Okay, and for BA1, BA2 recombinants, there's XC and XR and XL. Okay, so a lot of these scary names, but it's interesting for virologists. But I would emphasize that professional communities and general public don't need to be too concerned about this recombinant, because there is no real evidence that any of these recombinants are really achieving the kind of global dominance as that actual BA2 or BA4-5 is currently achieving. So at the moment, we're keeping an eye on this, but again, it doesn't make too much of a difference. Remember that even if it's a recombinant, it is still the same old spike. So our vaccines and antivirals would still be expected to hold very strong against these. So again, just to reassure that I don't think we should pay too much attention at the moment. Omicron, pure Omicron is bad enough, right? Okay, so I'm coming towards the end here, and I think in good time, because I did want to set aside more time for a Q&A. In summary, how likely is a case rebound and eventual sixth wave in Hong Kong? 100% it's going to happen sometime this year, perhaps by the end of summer, we're going to see a spike in cases. Policy is less predictable. We'll see at the time what happens in terms of the social distancing measures in Hong Kong. Which variant is likely to predominate? At the moment, it's all about Omicron. Different sublineages of Omicron like BA2 or BA4 and 5 have really taken over. And if anything in Hong Kong, I'd expect BA4, 5 or BA2, 12, 1 to really come next. If you're talking about variant of concern, apart from Omicron at the moment, we haven't seen any sign of such a new variant of concern, and when and where that would happen is unpredictable. But as I said, the equation really doesn't change in terms of building community resilience against the virus. How do we prepare? We focus on vaccinations for elderly, this section of the population and other vulnerable patient groups. We focus on accessibility to antivirals in community settings, and we really aim on measures that actually reduce hospitalizations and severe disease. And we're talking about pharmaceutical interventions at the moment, rather than onerous non-pharmaceutical interventions that essentially cause society to shut down. Because, I mean, we really need to move on because the rest of the world has already moved on and we now have to catch up. Okay, so that's actually all I'd like to say at the moment. I would be more than happy to take your questions, and thank you once again for inviting me. Thank you.
Thanks a lot, Dr. Siddharth. Yeah, I think as quite a lot of members still remember that it is right at the beginning of the fifth wave that during the last webinar, you told us that the use of the RAT to screen our patient is a very useful tool to help to protect our staffs and also protect our other patients. Yeah, and then I think that nowadays in Hong Kong, I think that most dental clinic, when they see their patients, that they will use the RAT as a kind of measures to check whether that they are COVID positive or not. Yeah, and I think that this actually become a usual practice. Has been adopted by the clinic now, and then it is a very useful way to do it. Yeah, and also that I think that we dentists as the healthcare front line, whenever our patients come in for treatment or review or anything, that we should encourage them and then remind them that the vaccination is important. And then not just the patient himself, but also help to remind the family members to take the vaccination, and also that when the appropriate time comes, he has to take the first shot or the free shot. Yeah, and then I think that our members can help on this part. Yeah, and now we've got the questions on the floor. Yeah, I will just repeat the questions. Yeah. Because this question is from Dr. Aaron Zhu. Yeah. Okay. Aaron said that for the impact of the COVID-19 is originally generated much concern of it, and it was spreading coronavirus from human to human. Yeah. And then after the SARS outbreaks in 2013, yeah, and we are actually that noticed that for the first and the fourth wave, yeah, and especially that our younger generations were forced to stay home. And at the beginning of the fifth wave, yeah, it's more youngsters has severe signs and symptoms, but was blamed on the low vaccinations level among this age group. Yeah, and he thinks, is it a possibility that because these youngsters are all confined at home, therefore their immune system response will decrease dramatically, and also that the personal interaction will heavily limited, therefore also prevent them has a proper psychological and a social development. Yeah, and as health workers and researchers, and then is it better that to live it with the COVID? Yeah, just like we live with the flu, or to avoid it? Yeah, and this is Dr. Aaron G's question. Yeah.
Okay, thank you very much. So actually, the child pediatric issue is quite controversial at the moment. I will say this, the severity of Omicron among children in Hong Kong has been more or less similar, perhaps slightly higher than the severity of other respiratory viruses such as influenza and para-influenza, according to a study by Hong Kong U Pediatrics. They did try to compare Omicron against other previous variants, but actually it's impossible to do that study in Hong Kong because for previous variants, we hospitalized every single child with COVID-19. But during the fifth wave, we only hospitalized children who were more sick because a lot of infected kids were simply staying at home. So that means that you're comparing a more severe subset of Omicron kids against the entire COVID-19 childhood population in previous waves. So it's very difficult to do that study in Hong Kong. Overseas experience again suggests that the Omicron variant infection in children is again severity-wise is more or less similar to previous variants of concern. However, the incidences of certain types of infections like croup, laryngotracheobronchitis, right, upper respiratory tract infection is more for Omicron. So that's something that's very clear. Now, Professor Lau Yulong has actually raised this point of whether, staying at home, wearing a mask all the time is actually affecting the children's immune systems in terms of dealing with respiratory viruses, right? We actually don't have any definite proof to either support or refute this hypothesis. But what I would say is that as we start opening up, inevitably we're going to open up society. And when that happens, we are going to see a lot of respiratory viruses coming back, like influenza, adenovirus, respiratory syncytial virus, etc. And then unfortunately, we are going to be in a good position to judge whether the severity in the pediatric population for these infections is more or less compared to, more or similar compared to the pre-pandemic situation. From the rest of the world, I haven't really seen any signal that respiratory viruses are getting more severe in the pediatric population because of staying at home or mask wearing, but time will tell. The immune system is always a bit of a mystery. So how it actually reacts to this kind of sequestration remains to be seen. And I do think that we do need to the virus is going to evolve, so we need to evolve as well. We can't always keep running from the virus. And as I said, we have to focus on pharmaceutical interventions to mitigate the effect of the virus on our society, rather than always shutting down society to keep the virus out. So it's just not a sustainable way of doing things. Because the situation in Hong Kong has changed dramatically over the last few months in terms of huge numbers of infections and the kind of background immunity against severe disease that I referred to in the talk.
Okay, I got another question for you, Dr. Siddharth. When I read the news today, it is quite clear that the China government is still insists to use the zero COVID policy. Yeah. And it is they have made a prediction is that if they do not use the zero COVID policy, they will estimate about 1.5 million people will die. And therefore, at the moment, seem to be that they have to still keep on this strategy. And one of the reasons is that the vaccine, the activated virus vaccine they are using, the immune protection seem to be not as good as the mRNA, and therefore there's some sort of this free risk coming out. How is your view on the situation? And then can anything way forward, because the China is talking about 13 or 14 billion of people. Yeah, it is quite a large number. Yeah, and if they have to use a new vaccine to do vaccination for everybody, it will take quite a long time to do so. Yeah.
Yeah, so the mainland at the moment is basically like Hong Kong in December 2021. So they have a large population of unvaccinated elderly, unfortunately. So the vaccination rates in the elderly, especially 2 or 3 dose vaccination rates, are not great because of many of the factors that affected the rates in Hong Kong as well. Because people say if there's no COVID locally and we're so committed to dynamic zero, then what's the point of getting vaccinated? So that's actually what's going on in the mainland as well. So I guess the mainland looks at Hong Kong and how horrible the fifth wave was in Hong Kong, and they just don't want to go through that at the moment, because replicated on a national scale, you can imagine the number of deaths. And that modeling study from that Shanghainese university actually estimated the huge mortality that and disruption to healthcare that would arise. So I fully understand why they're pressing so hard with dynamic zero, but obviously, as I again said during the talk, that would eventually have to be a transitional phase. And they would look at other examples, like, for example, New Zealand, that also stuck to zero COVID for a very long time, but they vaccinated their elderly. We're talking about 90 to 100% vaccination rates, and then they open up and things are fine, actually. Huge numbers of infections, but flat in terms of severe disease or fatal disease. The other thing the mainland is already starting to do is to start thinking about Paxlovid, obtaining Paxlovid locally, producing Paxlovid locally, the antiviral. So if and when they decide to loosen things a little bit, they have these great pharmaceutical interventions to keep levels low. But until these preconditions are met, I don't see that they're going to loosen up, and they have their reasons for that, definitely. So it's going to take a long time for sure. We're looking at probably another year or so or more.
Okay, thank you, Dr. Siddharth. Any more questions from the floor? Yeah. Okay, if anyone get your questions, you're still most welcome to send to the Dental Association, and then we will forward these questions to Dr. Siddharth, and then he will try to answer your questions. Yeah, and we will just keep post Dr. Siddharth's Facebook post in our Hong Kong DA Facebook, so that we can share his wisdoms on the COVID-19. Thank you.
Thank you very much.
Thank you very much. Yeah.
See you. Bye-bye.
Bye.
Bye-bye.